Thank you everyone for tuning into this session, The Power of Genetics, What It Means to You and Your Family. My name is Dr. Alicia Tone, and I'm the Scientific Advisor at Ovarian Cancer Canada. I'm joined today by two ovarian cancer survivors and patient partners in research team members, Peggy and Sylvia, a BRCA1 Pre-vivor, Katie, and a genetic counselor, Jeanna. So the goal of this session is to highlight the impact of learning about your genetic makeup on both the care of individuals diagnosed with ovarian cancer and their close family members. You will see that genetic testing can provide additional treatment options and opportunities for cancer prevention. Genetic counselors play a key role in this pathway. So before we get to know the other women on the panel, I want to ask Jeanna McCuaig, genetic counselor at Princess Margaret Cancer Center, to set the stage a little bit and explain what is genetic counseling and why is it important? What type of information is covered? What is different about pre-test and post-test counseling?
Thanks, Alicia. I'm happy to be here to talk with you all today. So genetic counselors will work in different areas of practice. So some people will work in the general clinic, some people work with adults, with kids. As somebody who focuses on cancer specifically, my role is to meet with people who have either a personal diagnosis of cancer, a family history of cancer, or sometimes it's both of those things, to talk about the possibility that there could be an inherited risk in the family. So a specific genetic risk that can be passed from parents to children, that can predispose or increase the chance for someone to get a cancer. And so we cover lots of information, and a lot of that really depends on the individual. Sometimes people have more questions, and so that might direct really what things we discuss. But essentially in a pre-test appointment, so before someone has genetic testing done, we'll take some time to review their personal and family history. We talk about what kinds of things we expect to see in families where there's an inherited risk, so we can really show someone what their family history looks like compared to, someone who might have a very high likelihood of having a genetic predisposition. And in that way, we can provide them a clear assessment of what their risk might be. And for individuals where a genetic test might be indicated based on their personal or family history, we talk a little bit more about the genetics of cancer, how a cancer risk can be inherited, and most importantly, what are the benefits and limitations to knowing whether someone has a hereditary cancer risk or not, because some people prefer not to know that information. So we give people information and have a discussion so that they can make an informed choice as to whether they want to have genetic testing done or not. For those people who do want to have testing done, we can facilitate that. It's typically done through a blood test, though there are some centers who would do it through saliva or other samples. And then during a post-test appointment, we would meet again to review the results. And so there are really three different results that could come back from a genetic test. Could be a result is negative, meaning we don't see a hereditary cancer risk. We talk about the limitations of the testing, that our test is not perfect and there could be things that are missed, but essentially we rule out what we know in terms of hereditary cancer risk, and then we make any recommendations based on their family history and personal history in terms of any other cancer screening. Could be a positive result comes back, meaning yes, we find a hereditary cancer risk, and that's a more detailed discussion about what are the specific risks associated with the gene that's seen in the family, what are the screening recommendations, and we would help to facilitate any of those referrals. And then also how this impacts their family members and how they can go about sharing information with other people in the family. And then we can also have a third type of result, which is an inconclusive or uncertain result. And these can be confusing for people. The way that I explain things is that essentially people look different. We all look different, and our genetic code is going to look different. And a difference is not something that's necessarily bad, right? And so the same way in our genetic code, we can see differences that we haven't seen enough times before to know if that's something that's related to cancer risk or is just part of natural differences between people. And for those results, we treat them a little bit more like negative results in that we don't make any recommendations, but it's things that we encourage people to keep in touch with us over time. And then we talk about different support groups and things like that, really depending on what a patient's particular needs are.
Thank you, Jeanna. Now I'd like to give each of our ovarian cancer survivors an opportunity to tell us a little bit about their story and how genetics specifically has played a role. Peggy? Peggy, you're muted, actually. Still muted.
We practice this. Can you believe
Yes,
that? We actually
ahead.
practice this. So, hello, my name is Peggy, and I'm going to read my answers as we all want to get out of here on time, because if I go off script, I could take hours. I have a long story, and we don't have time for all the details. But I guess that is good news, right? That I have a long story. The road to my diagnosis started about 2 years before my surgery, which was when I was actually diagnosed. So in January of 2014, I woke up from surgery with the diagnosis of cancer. And 4 weeks later, pathology confirmed high-grade serous ovarian cancer, stage 3C. After recovery from surgery and the shock of diagnosis, I started chemo on my 50th birthday, completed 6 cycles of cisplatin and Taxol, and declared NED. My gynae-onc was highly suspicious that I had a genetic mutation, and he set me up for genetic counseling. There is a strong history of breast cancer on my mother's side, so I was naturally expecting a positive result. But after the extensive counseling process, the deep family history that was a part of that, it was the opinion of my counselor that the possibility of a mutation was likely on my father's side, as he had had melanoma and his mother had died of women's cancer. We now suspect that that was ovarian with my history. So my counselor was expecting a diagnosis of BRCA2, and I did end up with a positive result, but of BRCA1, and it's definitely from my father's side. As my mother had been a patient at the same cancer center, and they still had access to her tissue samples, with my permission, they tested her sample and it was negative. And both my brother and I ended up being positive. So we knew that it didn't start with me. It had to have come from my father, who had predeceased us. I was diagnosed with my first recurrence in 2018, which was 4 years to the day of my first diagnosis. I went back into treatment, after which I received Lynparza by prescription. And almost 2 years later, and again, a new tumor growth. And because it has been the beginning of the pandemic, treatment was delayed by 4 months. I had radiation, and 4 months later, a new tumor grew, so back on carboplatin. I had become resistant, so we tried targeted radiation again, as it was a new site, so on and on and on. I'm not sure what number recurrence I'm at, but I am currently in diagnosis again. So we'll see what the scans say at the later this month, but I am hopeful.
Thank you for sharing, Peggy. Sylvia?
Hi, everyone. Thanks for the opportunity to share my genetic story. I, too, am going to be reading from my cheat sheet. So my mom was diagnosed with high-grade serous carcinoma in 2002 at age 77. She passed away the following year. My aunt, her sister, had cervical cancer in her 40s, but it was caught early and it did not take her. I was diagnosed with stage 3C high-grade serous in 2017. My cancer, including my CA-125 number, which was just shy of 3,000, was eerily similar to my mom's. I had genetic testing in 2018 while undergoing treatment. I got the news I was BRCA2 positive in May 2018. I was not surprised. Of course, this mutation was from my mom. I immediately informed my brother and quickly got to work informing cousins on my mom's side. 3 cousins on my mom's side were tested. All were negative. At that point, I had a nagging feeling. Could this mutation actually be from my dad? Where do I begin to try to figure this out? My dad passed away in 1980 at age 50 of a heart attack. He was the only of his siblings to have come to Canada, and we lost contact with his family members in Europe. I do, however, recall he had a sister who passed in her 30s of breast cancer. Out of the blue, in October last year, I had a second cousin on my dad's side in Germany reach out to me. She was building our family tree and had just found out she had relatives in Canada, my family. In getting to know her, I shared my cancer story and informed her of my BRCA2 mutation. I also wasted no time in trying to find out family history of cancer on dad's side of the family. She mentioned there was another cousin who had been diagnosed in her 30s of breast cancer. This piqued my curiosity. My newfound cousin in Germany quickly got to work. She discovered that our cousin with early onset breast cancer already had genetic testing and had tested positive for the BRCA2 gene. Not only that, it turned out we had the exact same variant of the gene. Mystery solved. The gene is from my dad. I guess the moral of the story is things are not always as they seem. Never assume where the gene came from. I was completely blown away to find out that this was from my dad. Thanks for listening.
Thank you, Sylvia. So for those of you who are not aware, a pre-vivor is someone who has inherited a mutation in a hereditary cancer gene, but has not been diagnosed with cancer. So Katie, could you please tell us a little more about your experience as a pre-vivor? Oh, you are muted, Katie.
Thank you, Alicia. I'm really excited to tell my story. Like everybody else, I'm going to be speaking from my notes. My name is Katie Lark. I was diagnosed, I'm 32 years old. I was diagnosed having BRCA1 at the age of 25. I had a double mastectomy with expanders at 27 and a total hysterectomy as well as removal of my ovaries and fallopian tubes at the age of 30 in January of 2020, right before the pandemic hit. I always knew that I had a family of history as my dad's mom died of ovarian cancer at the age of 40. My dad was 7 at the time. His mom, my grandmother, had been ill for 2 years. Their private insurance would only cover the first $30,000 of costs, as this was before the provincial health insurance was put into place. She had worked at the Ontario Women's College Hospital in Toronto for many years as a nurse. When she got sick, her nurse friends were kind enough to come and help with home care for free. Well-known friends of my grandfather's, who was an Anglican archdeacon at St. Paul's Rummy side at the time, church in Toronto at the time, were kind enough to help cover the costs after insurance. Knowing my family history, my aunt, who was in her 60s, who was also a nurse in her 60s at the time, noticed that she was bleeding. She had started bleeding even though she'd already been through menopause. Her doctor didn't like the test results that they had got when they sent her in. So they sent her in for surgery and did a total hysterectomy. After the surgery, the pathology results came back as pre-stage 1 ovarian cancer. Soon after that, she did a genetic testing and it came back positive for the BRCA1 mutation. She decided to get a prophylactic mastectomy after she found found breast cancer. She's alive today and thriving. My aunt's test results came back. After my aunt's test result came back, my dad went to CHIO, a local hospital here in Ottawa, and got tested for the exact same mutation that my aunt has and came back positive. After speaking with my aunt and my dad, my younger sister and I decided to get tested at CHIO as well. Genetic Counsellor sat us down and spoke to us individually and asked us if we were sure we wanted to be tested and we weren't being pressured by our family. As well, do we feel that she also asked if we felt that this would affect our relationship with one another if one came back positive. We both said that it wouldn't affect our relationship, and it still hasn't. We were sure we wanted to get tested. 3 months later, the results were in. My parents and I went back to CHIO to see the genetics counselor. We called my sister, who was in Victoria, BC University at the time, It was about 7 a.m. there. Her results came back negative. My parents, soon after that, they did her lifetime risk, and it was less than the average person for breast and ovarian cancer. After that, they gave us my test results, which came back positive. I remember feeling extremely crushed and not understanding how I was going to tell it what this would mean for the rest of my life. At the time, I had a boyfriend. When I told him my test result, he didn't speak to me for a week. After that, when he started speaking to me again, I got my stuff back and I broke up with him, and I've never spoken to him since. Soon after that, a few months after that, I had my first appointment at the Women's Breast Health Clinic. They asked me if I wanted to have my ovaries out at 25 because of my family history. I said no. I didn't understand what it meant what I was going through. So they started doing yearly MRI screenings and gave me information for a local support group. After having 2 yearly MRIs and regularly going to support group meetings, I decided I had enough. I never wanted to do one of those MRIs again after having such bad anxiety attacks after each one. In the fall of 2019, I started having bad pain in my abdomen, started feeling unwell, so bad that after seeing my doctor, she sent me straight to the ER thinking that it was my appendix. It wasn't. After that, I were multiple trips back to the ER and to the hospital trying to figure out what was wrong, so much so that I spent a whole weekend in the hospital once during doing tests. I finally saw my surgical oncologist. He just said that it was probably just endometriosis and there wasn't much that they could do. Since we already had the surgery scheduled, we would just deal with it then. Surgery day came. I remember feeling that morning, checking in for surgery, feeling so sick and unwell. I didn't even want to go ahead with the surgery. I wanted to go home, but I remember that if I canceled, it would be probably another year before I got a date. I'm now glad I didn't back out. After the surgery, once I was awake enough, the nurse called my boyfriend to let him know I was okay to come back and see me. I remember waking up feeling so much better, no more sickness. I want women out there to know that it is as hard as it is to go through, that you don't need a partner in life to get through this. You can, as long as you have a good support system around you, you can get through anything. I know I couldn't have done it without the support of my close friends and family. As long as you have a good support system around you, can get through anything. And even if we have never met, you can always reach out to me on social media. It's LarkK89 is my Instagram. If you ever want to talk or need some advice, I will do my best to help you in any way I can.
Thank you so much, Katie, and kudos for breaking up with that boyfriend.
Best thing I ever did.
Yes. So I'm going to ask you a question first. So can you tell me about your experience with risk-reducing surgery, including the counseling you received prior to going for surgery? Was there anything about the recovery process or side effects that surprised you and should be discussed in more detail prior to surgery?
That's a really good question, Alicia. I did not receive any counseling before my risk-reducing surgery. I had a few appointments with surgical oncologists. That was with one was with the initial meeting to discuss the surgery, what it would entail. The next appointment was to discuss the pain I was having in my abdomen that turned out to be endometriosis. Some of the things that I found after surgery were how bad the side effects for menopause were, and that the doctors had spent more time discussing what you would be dealing with once you were no longer producing estrogen naturally. Some of the side effects that I wish were discussed further were how hard it is to find the right hormone replacement therapy and that works for your body. Developing new food sensitivities, for example, I used to love shrimp and now it makes me sick. The weight gain and how fast it would come on. No one mentioned how quick the loss of hormones would make itself known and how miserable it makes you. The daily headaches, the vaginal dryness, low sex drive, belly bloat, insomnia, joint pain, bone density loss, and how you lose most of your bone density in the first 2 years after surgery if you're not careful. How there can be an early onset of osteoporosis if there is no guidance on bone health. Hair loss can also happen if you are not able to take hormones. Heart disease increase with no supplements. The emotional changes, mood swings, the effect of lack of hormones and on mental health, initial changes in cognitive abilities. I'm currently participating in a research study based out of Montreal and Toronto, where they're studying the surgical effects of cognitive menopause. The cognitive effects of surgical menopause. They're always looking for new patients. If you want to know more, feel free to send me a message and I'll happily pass along their information.
And that's it. Thank you, Katie. And a lot of the things that Katie is touching on are findings that we found in a larger survey and interviews with pre-vivors, and it's something we're really going to go after. So like Katie, Sylvia inherited her BRCA mutation from her father's side, as she's touched on a little bit. This story really demonstrates two things. So it demonstrates the importance of paying attention to both sides of your family tree when it comes to cancer, and communication of genetic results with family members. So could you elaborate on this a bit for everyone, and also lessons learned?
Sure. So in speaking with my newfound cousin from Germany, I think she mentioned something about it took me meeting you across the world to find out about this mutation in our family. And I was so surprised to hear that, because her cousin, lived in the same town as her, and never bothered to share the information about her mutation to direct family. And so I think what I've learned is there seem to be kind of two types of people when it comes to genetic testing. There's the take the bull by the horns kind of people who want to know, they want to be proactive, they want to learn everything they can. And then there's, the other ones that kind of want to just let the chips fall where they may, and they don't want to know. Something that I'm passionate about is for the people who don't want to know, if you have children, I think it's your responsibility as a parent to give them the information and empower them, give them the opportunity to decide for themselves. Maybe you don't want to know, but it's not all about you. You've brought children into the world, and just because you've chosen not to do anything with your potential mutation, that doesn't mean you should take that power away from those under you, or relatives and whatnot. So I think that was the most disturbing thing, to find that people didn't want to know. I just assumed everybody was like me and they wanted to know everything they could, and let's get tested and let's tell everybody. And that's not the case. And I was a little bit shocked to find that.
Thank you, Sylvia. So Peggy, learning of your BRCA1 mutation opened up new treatment options for you. Can you please tell us about that?
I just first want to say, Sylvia, I agree with you about not being afraid of the tests or the results, or being afraid but doing what's in my
opinion, them anyway.
Right thing. Yeah. So the BRCA1 mutation designation qualified me for a clinical trial. So I was on the clinical trial SOLO-1, which we heard about a little bit earlier, and it was for the drug which is now marketed as Lynparza. You may also know it as olaparib. I was on the active part of the trial for the full 2 years with a steady CA-125 and no evidence of disease. Lots of follow-up stuff on the study, so they watched me really closely. My BRCA1 designation also qualified me for enrollment in the high-risk breast cancer screening program, which I still faithfully follow almost 8 years later. As a matter of fact, later this month. When I faced my first recurrence, I asked to be unblinded from the clinical trial. If I had not been on the drug during the trial, if I'd been on the placebo, then I wanted access to Lynparza, which is a PARP inhibitor, post chemo. Now, it turns out that I was on the drug, and it was probably why I was NED for so long. And so then they said, well, you've been on it and you've had a recurrence. So I had to really advocate for myself, my specific case and my specific timeline. And I asked for the drug again and fought for it. And my oncologist got on board, and yippee for me, I did great on chemo and was able to go back on Lynparza. And for another 2 years it was another 2 years before my next recurrence. So, yeah.
Thank you, Peggy. So unfortunately, you requested genetic testing in 2007, 7 years prior to your own diagnosis, but you were told you did not qualify. So could you tell us more about that experience and any important lessons that you've taken from that?
In March of 2007, my mother passed away from breast cancer. And 3 months just prior to my mother's death, her sister passed away from breast cancer. I knew that they had both been tested for genetics, but I couldn't remember the result. So I went to my doctor, which is my mother's family doctor, and asked to be tested. And I was told that I didn't qualify and my doctor would not refer me for testing. So I thought, okay, fine. So I called the hospital where they did the genetic testing and was told that I would need a referral from my family doctor. So it was a vicious circle that kept ending with my family doctor. And at the time I had other battles to fight. So that one kind of fell by the wayside. I have subsequently learned that I did not qualify because my mother tested negative. But I wasn't informed of that, only that I did not qualify. And the why for me at the time was significantly important. It would have really relieved years of anxiety. I always, after my mother's diagnosis, considered my breasts toxic and I wanted them gone. And if I, known that I wasn't at risk, then it would have relieved anxiety, which in my case would have actually been a false sense of security, for I am truly BRCA1 positive, but not through my mother's bloodline, but through my father's. So just imagine, though, how different my journey would have been if I had discovered my risk factors before being diagnosed at stage 3C. I could very well still be speaking as part of this panel only as a pre-vivor, not a survivor. So the lessons sometimes take life lessons sometimes take a lifetime to learn. And I am still learning that you should never stop asking. I am learning that my anxiety and fears are part of me and therefore a part of what needs to be listened to and cared for. I am learning that the right doctor for me is the one who hears me. And I'm learning that with information comes knowledge. With knowledge comes the transformation from powerlessness to powerful, the transformation from patient to self-advocate. The genetic counseling process was illuminating for me. It gave me knowledge and therefore power. The depth and breadth of the knowledge shared, the care for not just me, but for my family is heartfelt. And my daughter, both of my daughters were tested. They each received a different diagnosis. And my daughter, who received a positive diagnosis, still receives regular follow-up calls from our genetic counselor. My wider family has been tested, and those that are positive are making plans and being proactive. It has already saved the life of my niece, who at the age of 26 had a prophylactic mastectomy and the later pathology showed TCIS. It will most likely save the life of my daughter and my other niece, as they're both in care and being closely monitored. All are considering risk-reducing surgery once they reach 35. I'm grateful. Knowledge is powerful.
Thank you so much, Peggy. And I'm so happy that your relatives have this chance to, prevent cancer from occurring in the first place. Okay, so Sylvia, you also had some interesting conversations about genetic testing. So could you describe the conversations you had with your oncologist about whether you should have genetic testing?
Sure. So in my initial visit to cancer care, obviously it was mind-blowing being told that I had cancer. But I did ask the oncologist, I did tell him about my mom's history and my aunt, and what were his thoughts on genetic testing, and could this be hereditary? And his thought that because of my mom's age at diagnosis, and she was 77, his thought was that, there was very little chance that my ovarian cancer was hereditary from my mom. So we didn't really talk anymore about genetic testing from there. However, after my surgery, I was having a conversation with my surgeon and mentioned about having gone through all of this with my mom X number of years previously. And she said, your mom, she said, well, are you thinking about genetic testing? And I said, well, I mentioned it, but it was, it was kind of said that if I had, it was mentioned that my cancer was probably a fluke, that it was the same cancer as my mom. But I went ahead with the testing, obviously, and I did test positive. Now, of course, we know now that it was a fluke and it had nothing to do with my mom at all. So it was very interesting to find that out. I guess my thought is any woman with early onset cancer, such as breast or ovarian, should be given the opportunity to be tested. Even though my mom likely did not have the gene, and my cousins on my mom's side were tested and nobody had the gene. But I think early onset cancer is concerning and it should be looked at. And, if given the choice, I would have much rather been a pre-vivor like Katie than a survivor. But, I'm in the thick of it now and thankfully doing okay. Yeah, it's an interesting journey for sure. I think testing should be more readily available, and it seems to have gotten that way, but I think more can be done. I think we shouldn't have to jump through so many hoops to get the testing. So that's my opinion, for whatever that may be worth.
Well, I think it's worth a lot. Thank you, Sylvia. And before I ask the next question, there's a message coming through. Hugs to my lovely cousin, Sylvia, who raised my awareness regarding the mutation in our family. I'm really thankful for that. Anya, is that how I say her name?
Yeah. Thank you.
So related to that, Jeanna, can you tell us how individuals may access genetic testing or counseling if they're concerned about their family history?
Sure. I would say clinically, unfortunately, as Peggy mentioned, most genetic clinics need a referral from a physician. Doesn't necessarily always have to be the family doctor, though lots of times if someone hasn't had a cancer, it is coming from the family doctor. We get referrals though from people's oncologists, as Sylvia had mentioned, or someone's gynecologist. We have people also who don't have family doctors and will accept referrals from a walk-in doctor. We basically, because genetics is more of a consult service, we have to report things back to somebody. So it makes it hard for us to deal with self-referrals, unfortunately. And I think if anyone's concerned about their family history, it's a matter of unfortunately, sometimes being your own best advocate. And sometimes when we push a little bit more, eventually we can kind of break down some of those barriers and get the referral, though I appreciate that that doesn't always happen. And I'm sorry that that was, that's been the experience for some people. The thing that I'll mention too is that things have changed in terms of genetic testing criteria, especially in Ontario. And I can only speak really to Ontario, though I know people might be living elsewhere. But now we're able to coordinate testing for someone who has a family history of ovarian cancer in a close relative. So a child, a sibling, a parent, whereas previously we weren't able to offer genetic testing so readily to people who had not had cancer themselves, which ended up being a huge barrier for a lot of people. And it's only when another diagnosis happens that we're able to figure things out in the family. The other thing is we used to focus a lot more on high-grade serous ovarian cancer, which is still the type of ovarian cancer that's most often hereditary. But now in Ontario, we've expanded things out to really any invasive epithelial ovarian cancer. So people who have other histologies, we know it's less likely, but we are picking up hereditary risk there. So it's a matter of people being aware so they can ask their doctors, because I think a lot of physicians rightfully are focused on treating the cancer. And so sometimes we need to ask a question about genetics, and hopefully the physicians will be listening. You know, it's shocking to me when someone doesn't get a referral, especially when they've had a parent who's had an ovarian cancer, because these are like, that's to me a bit of a no-brainer to send to genetics. That sometimes it's a matter of just asking more questions.
Thank you, Jeanna. So before asking Katie the next question, I just want to share another comment. Katie, thank you for that testimony. Very touching, very informative. So pre-vivors like Katie, our community that we are starting to really engage with and want to do better for. So Katie, what kind of resources or community would be helpful for you as a young pre-vivor?
As a young pre-vivor, I would say that some things I've found is that have been very helpful for me going through this is that I know I'm never alone. I always have friends and family that are always around me. When I'm having a down day, which can happen more often than not, I always know that my friends are around as well. I have made, as well as the friends I've made from my support groups on social media, example like Facebook and Instagram. I have as well as another example, when I got the call to schedule my double mastectomy, I was visiting my girlfriend in Korea. And when I got the call, it was 4 a.m. in Korea. And I got the call, I scheduled the time, and I was freaking out at the time. And I posted in one of my Facebook support groups about it, and then a few minutes later I got instant support, and in terms of telling me that it was going to be okay, you know, things are going to get better, you had the date and time, and that helped me to calm my nerves and my anxiety and get on with the rest of the day. One thing I had when I was going through this is that I wish I had known more young people such as myself in their late 20s going through this and single to talk to about it and their story, who would be able to better to relate to is what it's like. This is one of the main reasons why I've agreed to be part of this panel. I wanted to share my story, and I want to be able to help people out there, young and old, with the things that I've learned. And I want women young and old to feel comfortable with what they are going through and know that even though we are not in the same city or province, that I'm available to help them through their journey.
Thank you, Katie. So Jeanna, after hearing these stories from Peggy, Sylvia, and Katie, Is there anything that really sticks out to you about their stories?
I mean, throughout hearing people, I have a list of things that I've written down. So, but I'll highlight a few things. And I think Katie had just mentioned just how huge support systems are. And so whether that's your family or whether that's other people, you know, I think that that's a huge support for people and help them to answer questions. So the physicians that people talk to can tell them, you know, here are the things that we might see, but they haven't been through it. And so sometimes being able to connect to other people who had a surgery young and to talk about, okay, there's one thing to talk about all of these side effects, but it's another thing to hear from someone who's actually gone through it. I think that that's hugely helpful. And sometimes it's nice to talk with someone who's not a close friend or who's not a family member, because then you can say things to those people sometimes that you just can't say to other people who are close in your life. And that's at least what I've heard from other people who've shared their experience with me. The other thing is in terms of getting information. So it might not be local to you, but there are other options of getting information. There's Women's College has a broad day, like our Breast Reconstruction Awareness Day, where even if you're not living locally, a lot of these things are now available virtually so that you're able to connect with other people in terms of making decisions about these preventive surgeries, because they are very individualized decisions, and talking about a surgery and having a surgery are two very different things. The one thing also, just listening to Sylvia and Peggy, a few things are, and we've mentioned this before, thinking about both sides of the family. And it's interesting that all of you have a mutation coming from dad's side, because we see more people come through genetics based on concerns with mom's family history, but we know we inherit our genetics from both sides of the family, also pass on to our sons and daughters. And similarly, people who have uncertain or limited family history, we do account for that too now, more than we used to, I would say, when we're looking at risk assessments. And things change over time. So the genetic testing criteria change over time. Also, the genes that we test, our ability to see mutations change over time. And I've noticed in the chat some people asking about RAD51D, BRCA1. So we used to really focus on BRCA1 and 2, and they'll still make up the majority of hereditary types of ovarian cancer. But now routinely when we test them, we're looking at 19 genes. So maybe you saw genetics a while ago and your results were negative, but it also might be worth people getting a referral back to say, look, is there anything that's new, any new testing? Because we lose track of people in genetics. We don't have a mechanism to get back in touch with everybody. And so it might be worth some people reaching back out. You know, I think that those would be kind of my main things. And just, you know, from genetics, we don't know who needs extra support, and not everyone has the bandwidth, as Peggy was mentioning, to reach out to families all of the time. But I love hearing from people, and I'm quite happy to answer any additional questions or get new information from the family history. So don't hesitate to reach back out to genetics if you've seen them before. We will make time for you if you want to hear from us. Just not everyone wants to hear from us, so you gotta let us know.
Thank you, Jeanna. So we do have a lot of questions. So before opening up for questions, I want to sincerely thank all of you for joining us today. Stories like yours, in addition to our ongoing work with pre-vivors, genetic counselors, obstetrician gynecologists, and gyne-oncologists from across Canada in our program work, are really informing our work as we focus our efforts on maximizing efforts to and developing resources related to genetic testing for those with and without cancer, risk-reducing surgery, and appropriate follow-up care, including medical and supportive care for individuals with the mutation in ovarian cancer risk genes. So thank you all for sharing. I do want to go to a few questions, but first, we do actually have a comment from one of your fellow patient partners in research, Shannon. You're all amazing women. Thank you for sharing your stories. I am BRCA1, and 2 of my 3 sons unfortunately have it as well. It's vitally important to me that this BRCA monster stops with their generation and my boys don't pass it on. I'm very interested in learning about what options are available to them for embryo testing with IVF, and I'm assuming this is for Jeanna. as I think this is the only way to ensure my grandbabies don't ever have to endure these BRCA cancers.
Yeah, and I'm sorry for your experience, and I do think we have a lot of people who are interested in figuring out, how do we stop this monster in the family. There are options for testing embryos. So people go through a process called pre-implantation genetic testing, where they would go through a regular IVF process, and they actually would take a single cell from the embryo and send it to the lab for testing to know which embryos have the mutation versus those that don't. And then they can use those that don't for transfer. So there are options for sure. Not every couple decides to go through that. And, different areas have different funding abilities too. So some areas there's not any support for IVF, which can be expensive. Also, they have to develop a specific test for the couple when they're doing the testing of the embryos, which even if there's coverage for IVF, it doesn't cover that test. So for some people, it's financially a little bit challenging. The other piece that I always say to people who are going that route is there's also not a guarantee that people are going to get an embryo at the end that doesn't have the mutation, because it's 50-50. And if you have 3 embryos, it's possible all 3 of them might have a mutation. The other piece of it is there's no guarantee that if there's an embryo for transfer that it will result in a healthy pregnancy. So I think with all of that, definitely there are options, but it's just a matter of people having a very frank discussion with the fertility doctors in terms of, what are the risks and benefits, what are the likelihood of, having a healthy baby at the end. The other piece that we didn't get to that's kind of related to is as people think about having preventive surgeries, particularly at younger ages, there's more discussion about freezing eggs to use for future embryos down the road. Someone might not have a partner. And so, it's not an option for everyone, depending on what kind of surgery they have. And obviously, if they have their uterus removed, that's a different scenario versus if they don't. But if people have any of those questions, those are all things that to ask and to get referrals to talk to specialists about your options.
Can I just make one comment on what Jeanna said? When I was 25, when I got first diagnosed with the mutation, I went to go see a fertility specialist. They offered to freeze my eggs, but they said it wouldn't be covered by OHIP, by the provincial health insurance, because I didn't have cancer. And they said that it would be $10,000 for the first year alone, as well as another $1,000 every year after that I choose to keep my eggs frozen.
Yeah, and this is why I'm saying there's these options, but it's not financially feasible for everyone. I do know the costs have come down, and part of the initial cost is probably having to do with the procedure of harvesting the embryos or harvesting the eggs, etc. But yeah, there's definitely a cost associated with keeping them. And just because the cost was one thing one year, the costs are always coming down for testing, for any of the fertility stuff. So it's just a matter of, I always tell someone, get a referral at the time that you're interested in getting the information, because things are changing just so quickly.
So before I get into a question for Katie, I just wanted to shout out to Peggy as well, because someone put a message. Peggy, thank you for being in the solo trial. So many of us have benefited now from Lynparza. Okay, so Katie, there is a question about, did your genetic mutation affect your ability to get life insurance?
My parents already had life insurance in place before I got the diagnosis, before I got tested, kind of thing. So I know other people have had a lot of a hard time with getting life insurance after they get the diagnosis, after finding out they have a mutation. Even though they don't have cancer, they definitely have a lot of trouble trying to get life insurance after that. So my recommendation is to try and get life insurance before you get the genetic testing, just to make sure, just in case, so then you won't have a hard time later.
Jeanna, can you comment on that as well?
I was just going to say, and again, it has to do with things are just moving so quickly. So currently in Canada, there is now the Genetic Non-Discrimination Act, and I'll find a link, I'll put it in the chat. But now basically there is law in place in Canada that says people cannot ask about your genetic testing results to provide a service. So that could be insurance, that could be employment. So it is covered now that they're not allowed to ask. So if an insurance company is asking you, that's something to consider reporting. It doesn't cover family history though. So if someone has a personal or family history of cancer that's significant, even though they can't ask about your genetic testing results, that might still impact people's ability to get insurance or premiums. But the genetic testing itself, they're not allowed to ask anymore.
Great, thank you, Jeanna. So there are a lot of questions about other genes, and you did touch on this a little bit, as well as there's a question about the association of specific genes with different cancers in addition to ovarian. So this could be an entire talk, but could you just very briefly, I guess the first question is really if a woman or a man inherits the mutation in BRCA1 or BRCA2, what other cancers are they at risk for developing? And then anything you know about those other genes as well. Maybe the most common one, like the RAD51C and D and BRIP1.
Yeah, so for males, the main cancer risk is prostate cancer, and that's BRCA1 and BRCA2, but there is a higher risk with BRCA2. There's associations with other cancers like melanoma and pancreas cancer, which are more related to BRCA2, which is why, Peggy, they would have thought, oh, probably BRCA2 in your family. And sometimes it's hard to know things that are happening in a family, what's coincidence versus what is indeed related to the mutation, because someone can get a population cancer in another cancer that's not related to their mutation. It just means that your risk of specific cancers is higher, but it doesn't mean your population cancer risk of other cancers is less. So those would be the main ones for BRCA1 and BRCA2. With the other genes, so RAD51C and D and BRIP1, really right now the evidence is just related to ovarian cancer risk. The risk is not as high as what we see with BRCA1 and 2, and they tend to happen a bit later. So when we talk about risk-reducing surgery, sometimes we can push that closer to natural menopause age, depending on the family history, because that would kind of tailor things as well. There is some emerging evidence. Could there be relationship with breast cancer or other cancers? But there's just not enough evidence right now for us to make specific screening recommendations. So that's all based on family history. The other piece that's coming up too is some of the genes. So BRIP1, RAD51C, BRCA2, you can actually inherit a mutation from mom and dad, which then can cause a different genetic condition that impacts kids. And so now we start testing partners more and more if someone has one of those gene mutations to get a sense of other reproductive risks.
Thank you, Jeanna. So one thing I do want to ask, and this can be for anyone who wants to share anything. So what is something that healthcare providers, family doctors, gynecologists, obstetrician gynecologists, any of your healthcare providers should know about the survivor or pre-vivor experience with genetic testing? And this, unfortunately, will probably close the session. Anyone?
Sorry, I was distracted by the chat. What was the question?
That's okay. So I'm asking if there's anything you think healthcare providers should know about your experience with genetic testing. Positive or negative?
My experience was all positive. It just was so delayed, right?
Yeah. So that's
I think
important to point out.
It is, and that, you know, this is something that our family doctors there again need more support and more education and advocacy around. Because for so much of it, it starts there, and we rely on our doctors to bring the issues up, right?
Yeah.
You know, genetic counseling is just, you know, not on your radar at all. And one thing, Jeanna, like I was tested 8 years ago, basically. Should I get tested again? I've had several rounds of treatment. Like things can change, or they've discovered new stuff. So is there a recommendation that way as well?
You know, it's a good question, Peggy. We often, when someone has a hereditary risk that's seen, we don't retest But given there's family history on both sides of your family, there could have been something else that's not BRCA1 and 2 that's coming from your mom's side. So it's not unreasonable. And things can change sometimes within a tumor, but because we do the genetic blood test, that's always what you're born with. So that doesn't change. But if we didn't look at anything beyond BRCA1 or 2, it's worth checking in with the genetics team you work with just to say, look, you know, there's other things. Maybe there's something else coming from mom's side that could be important for my family. Would you consider like updating my testing? Absolutely.
So
Good to know.
Thank you, Peggy, for bringing up the family physicians. And just, I want everyone to know that this is something that we're really looking into, and how to actually reach these family physicians, how to tell them about the importance of taking a family history and responding appropriately, depending on the family history, and refer on to genetic counseling. So there are a lot of questions, and we will address all of them in the chat. But for now, we're going to sign off. And again, thank you so much for joining us, all of you. And I hope everyone has a great rest of the symposium. Thank you.